وبحب اشكر استاذتي العزيزه استاذه الدكتوره سناء يوسف على دعوتي الكريمه، وبهنيها على نجاح المؤتمر. طبعا كلنا يعني الدكتوره سناء غنيه عن التعريف، وهي بصراحه يعني مش بتبخل عن اي حد يعني باي معلومه. ويسعدني ويشرفني ان انا اقدم استاذتي العزيزه استاذه الدكتوره رشا طريف. الدكتوره رشا طريف غنيه عن التعريف، دايما بنستنى محاضراتها اللي بتمتعنا بيها. دكتوره رشا طريف هتكلمنا النهارده على the bridging the gaps in obesity. اتفضلي يا دكتوره رشا.
مساء الخير على حضراتكم. بشكر حبيبتي أمنية على التقديم الجميل، وبشكر أستاذتي الجميلة الغالية أستاذة الدكتورة سناء يوسف على دعوتي إني أكون مع حضراتكم النهاردة. هتكلم عن bridging the gap in adolescent obesity, and this symposium is sponsored by Novo Nordisk. Let me open the scene by this very impressive piece of donut, and here let me ask you, which is stronger, the food or our will? إرادتنا أقوى ولا الأكل؟ إيه رأي حضراتكم؟ طبعاً بالإجماع الأكل طبعاً. طيب السؤال الثاني بقى، are we exhausting our pancreas? The answer is yes. Our pancreas is calling for help because we are eating a lot of unhealthy food leading to release of large amounts of insulin. And that's why type 2 diabetes is becoming more common than before in children and adolescents. And when we ask why, this is why, because obesity is taking the upper hand in global threat waiting area. We passed through a lot. We've seen the COVID-19, the bird flu, the global warming, the Russian-Ukrainian war, and in spite of all this, obesity is taking the upper hand. Pediatric and adolescent obesity is a growing global health problem. In 1975, 11 million child and adolescent were obese. In 2016, it increased to 124 million obese child and adolescents. And looking closely at the Arabs, Arab children are among the world's 10 heaviest children. And you can see that Egypt is among the top 10. الحمد لله لينا ترتيب في حاجة. احنا among the 10 heaviest in the world. So I think you agree that obesity is like an exploding bomb. Childhood and adolescent obesity is a disease and health issue, and this was described by most of the societies. It is a chronic disease and health issue. Another point is that obese child is liable to being an obese adult. And this is a research that predicted the incidence of obesity starting at the age of 2 years until the age of 35 years. And you can see here that obese child turns out to be obese adult with the same category. And this is a photo of Pediatric and Adolescent Obesity Clinic in Shams University, which was established in June 2000. It's a once-weekly clinic. We see around 30 patients per clinic with a multidisciplinary team working on that. And this is the protocol of obesity assessment at Ain Shams University, starting by clinical evaluation, investigating for the cause thyroid function, parathyroid hormone, excluding Cushing, genetic testing in some cases, and investigation for comorbidities. We do hemoglobin, fasting lipid profile, glucose insulin ratio, A1C, C-peptide, liver function, excluding polycystic ovarian syndrome, and polysomnography. And finally, sometimes we need the help of our colleagues in the genetics, hepatology, nutrition, and bariatric surgery. And let me take you to this real-life case scenario of this 13-year-old girl. She was born normal. She started to develop progressive weight gain, menstrual irregularities, hirsutism. She dislikes sleep. She has sleep apnea. Her father and maternal aunt are obese. There's type 2 diabetes in paternal grandma. She's very tall, plus 2.8. Her BMI is very large. The waist-hip ratio is high, meaning that she has abdominal obesity. She's in Tanner stage 2, and systolic and diastolic blood pressure are above the 95th percentile, and you can clearly see in the neck that the girl has got acanthosis nigricans. Her fasting blood sugar and fasting insulin are very high. The A1C was found to be high, 8.1, and this is in diabetic range, and the C-peptide is normal. So you can see that the girl has silent diabetes type 2, in spite of the fact that she was not complaining when she came to us. Her fasting cholesterol, triglyceride, LDL is very high, and the HDL is low, and the liver enzymes were high. So the diagnosis of this girl is exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, depression. Again, this is a very sad, but unfortunately a very common story that we see nowadays. And as you all know, obesity is only the tip of the iceberg. And there is a dangerous hidden part of the iceberg with a lot of comorbidities hidden below. In addition to metabolic syndrome, there are a lot of comorbidities like depression, cancer, gallbladder disease, sleep apnea, osteoarthritis, stress incontinence, and dysmobility, leading to a very poor quality of life. In addition, there is a heavy economic burden of obesity and its comorbidities. And please remember that obesity predisposes to premature cardiovascular disease due to metabolic complications. And as we all know, there are two types of obesity, the apple and the pear. Which is more dangerous, the apple or the pear? What do you think? Yes. This is the apple-shaped obesity. It's more dangerous because it predisposes to metabolic syndrome and cardiovascular risk factor. So please remember that abdominal obesity is the predictor of other components of metabolic syndrome, regardless the BMI. Even if the BMI is not very high, but there is abdominal obesity, we have to screen for metabolic complication. So as you've seen, there is a running vicious circle of complications predisposed by genetics and environmental factors leading to early mortality. But the question is, who presses the start button of obesity comorbidities? And the answer is insulin resistance and inflammation is the root which predisposes to other metabolic complications and cardiovascular disease. And visceral fat and other risk factors, in addition to unhealthy diet, leads to metabolic syndrome and imbalance in the insulin sensitivity, ending by cardiovascular disease. Another point is obesity-induced inflammation, which is triggered by unhealthy lifestyle. As we said, visceral obesity increases the tumor necrosis factor alpha, interleukin 6 and RA, CRP, leading to a state of inflammatory process ending by cardiovascular disease and type 2 diabetes. And this is how the journey starts. When we take the food, it goes to the stomach and is absorbed in the form of glucose. And this is the normal insulin response. Insulin triggers the cells to remove glucose from the blood. In the presence of insulin resistance, the cells ignore this message. They do not see the glucose, and insulin starts to increase high and high until the blood sugar becomes very high, leading to type 2 diabetes. And simply what happens, as you see here, we are hungry, we eat a lot of carbs and sugars, the pancreas produces insulin and the cells ignore the message. The pancreas produces more insulin and then insulin resistance occurs, ending by type 2 diabetes. And the unhealthy lifestyle exacerbates the vicious circle, and the vicious circle goes on. And as we know, there are a lot of risk factors for type 2 diabetes, with modifiable risk factors that we can change and prevent. And of course, obesity and overweight is on top of preventable risk factor list. And looking at the sequence of events of the beta cell function, you can see here that healthy beta cell becomes stressed and then fails, ending by apoptosis and type 2 diabetes. And when we translate these into numbers, you can see that the pancreas passes by the phase of a normal function, the insulin goes up with prediabetes in the stage of insulin resistance, and finally the insulin goes down and the blood sugar goes up, ending by type 2 diabetes. And let me tell you that unhealthy lifestyle exacerbates this arrow in the way of type 2 diabetes. On the other hand, healthy lifestyle can revert the wheel and the arrow back from the stage of type 2 diabetes to insulin resistance and normal function. So nutrition and lifestyle influence the course of type 2 diabetes in both ways. And this is the ISPAD clinical practice guidelines, very recently published in 2022. And they raised a very important question: to screen or not to screen for type 2 diabetes in obese children and adolescents. Who would say we have to screen? Shall we screen? Yes. Thank you very much. We have to screen. Even if the child is not symptomatic? Yes, even if the child is not symptomatic. We screen at the age of 10 years or at the onset of puberty, or if the BMI or the weight status is above 85th percentile, plus any of the following: family history of type 2 diabetes, high-risk race, maternal history of diabetes or gestational diabetes, signs of insulin resistance like acanthosis nigricans, and any associated features of metabolic syndrome. And these were reported by ISPAD clinical practice guidelines and American Diabetes Association Standards of Care 2022. Again, inflammation triggers hypertension, and the most important predisposing factor is visceral obesity, increasing the leptin and decreasing adiponectin and free fatty acid, which stimulates sympathetic nervous system, activating the renin-angiotensin system, leading to hypertension. We also have obesity-induced dyslipidemia, again and again, triggered by visceral and abdominal obesity, increasing interleukin-6 and tumor necrosis factor alpha, which increases the free fatty acid, exacerbating insulin resistance and leading to atherogenic dyslipidemia. And this is how the atherogenic dyslipidemia looks like. You can see it predisposing to coronary artery disease and cardiovascular complication. And in the past, we used to describe this in old people. Unfortunately, nowadays we see atherosclerotic plates and coronaries in adolescents because of obesity. What about obesity-induced fatty liver? Again, triggered by oxidative stress, simple steatosis leading to NASH, non-alcoholic steatohepatitis ending by liver cirrhosis. So the Journal of Clinical Endocrinology and Metabolism strongly recommended to screen any adolescent obese for comorbidities: diabetes, prediabetes, dyslipidemia, pre-hypertension and hypertension, polycystic ovary disease, NASH, sleep apnea, and psychiatric problem, because early diagnosis avoids early mortality and morbidity. Now, let's go back to the case that I started with, how to manage our case. Remember the case? She had exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, and depression. And as you see, it's a list of interconnected problems which exacerbate each other. And this is the cornerstone of management of any child with obesity. We keep telling our patients diet, physical activity, behavioral counseling, and family-centered intervention. And this is what we all know. This is very well known. But there are some novel options that are progressing very fast in the field of adolescent obesity. And the speed of the options is growing very, very fast, especially in the past 2 years. Our aim is to shrink the fat cells. And when we speak about adolescent obesity management, the question is really puzzling. Which way shall we go? Is it the healthy lifestyle? Or is it the other extreme, bariatric surgery? Or is there a solution in between, which is pharmacotherapy of adolescent obesity, which could solve the problem? And here you can see the algorithm proposed by Journal of Clinical Endocrinology and Metabolism on the approach of how to manage an adolescent with obesity. And you can see that we consider pharmacotherapy or surgery only after failure of lifestyle modification for 6 months. Now let's go back to the girl. You can see here that the girl came with silent type 2 diabetes. What's the suggested management? Can I give you some choices? What's the treatment here? Metformin plus lifestyle. Who votes for the first choice? Who says yes for the first? Thank you. Okay. The second choice, who would vote for the second choice? Basal insulin, metformin, and lifestyle. Who would like to start insulin? Okay. Who would like to treat as DKA and give IV fluid? No one. Of course not. She did not present with DKA. And why not give insulin? Because this is the answer proposed by ADA in 2022. You can see here, if the A1C is less than 8.5, you give metformin in addition to healthy lifestyle. If the A1C is above 8.5, you add basal insulin. And of course, if the child presents with DKA, you treat as DKA. And then you revise the antibodies to exclude type 1 diabetes and continue accordingly. And unfortunately, this girl failed to lose weight after a trial of lifestyle modification, and she is still on metformin. She couldn't stop eating. Can I ask you, is our case a candidate for adding anti-obesity medication? Who says yes? Yes. Everyone says yes. No problem. Yes, we can. And these are the recommendations published in the Journal of Clinical Endocrinology and Metabolism, Endocrine Society Clinical Practice Guidelines. We can add anti-obesity medication after failure of lifestyle modification for 6 months in adolescents above the age of 12, and re-evaluate if there is no reduction more than 4% in the BMI Z-score, revise the treatment. And this is a list of the approved anti-obesity medications in adolescents. You can see here that liraglutide is approved by FDA and by EMA, orlistat above the age of 12 as well, phentermine above 12, and semaglutide January 23. And please remember that metformin is not an anti-obesity drug. Please don't prescribe it to lose weight. It's approved in children above the age of 8 who have insulin resistance, prediabetes, or type 2 diabetes, but it's not an anti-obesity medication. Can we start liraglutide in this girl? Who says yes? Thank you. Yes, there is no contraindication. We tried lifestyle, she failed, and she is above the age of 12. So, yes, we can. Indications of liraglutide in obese adolescent if the body weight is above 60 or BMI above 30. Liraglutide is a once daily human GLP analog which reduces hunger and increases satiety by acting at the arcuate nucleus. And here you can see that it stimulates the POM-CARD pathway and inhibits neuropeptide Y and agouti-related peptide. And the net result is that it increases satiety and reduces the hunger, which decreases the appetite. And this is a research that clearly demonstrated that liraglutide influences all dimensions of appetite. It increases the satiety and the fullness, and it decreases the hunger and prospective food consumption, which means thinking about food. What am I going to eat in the future? And this is what happens with morbidly obese. And this is the dose escalation way to improve the tolerability. It's very important to start with the first dose of 0.6 and to increase on weekly doses or according to the tolerability of the adolescent until we reach 3 milligrams. And some of them are even tolerated at doses less than 3 milligrams. Another beneficial effect is in type 2 diabetes. It changes the baseline A1C, and this research showed a significant decrease in the A1C in adolescents with type 2 diabetes, and significant change from the baseline fasting blood sugar, and a change in the baseline BMI Z-score being lower in children with type 2 diabetes. And so the conclusion is that liraglutide up to 1.8 milligram per day added to metformin with or without basal insulin is efficacious in controlling type 2 diabetes. And this was published in the New England Journal of Medicine. So we can use it, and the upper limit is 1.8 milligram. And this is a new approval here in 2022, published in Clinical Endocrinology, FDA approved, approved liraglutide for pediatric patients with type 2 diabetes, and these are pharmacotherapies and, of course, bariatric surgery with experienced surgeon and in post-pubertal near final height. The last point, would you like to investigate for menstrual irregularities? Yes. And the suggested investigations here, FSH, LH, and the ratio is impaired, testosterone is high, and the adrenal androgens are normal. The ultrasound showed enlarged ovaries with 5 follicles. Does this go with PCO? Who says yes? No? Okay. I'm speaking about the ultrasound. These are the criteria of PCO by ultrasound. More than 12 follicles and increased ovarian volume. Please remember that ultrasonographic findings do not equate the diagnosis of PCOS, because some girls with PCOS do not have the ultrasonographic finding. And if you look at the type, this girl goes with the acystic type of PCOS, which does not show follicles. PCOS is an interaction between the genes, environment, visceral adiposity, leading to androgen excess and insulin resistance. And the pathophysiological link starts by hyperinsulinemia, hyperandrogenism, ovarian dysfunction, and cardiovascular disease. And of course, you all know that PCOS is more prevalent in obese, although it is not in every case. Some of them are lean. And weight reduction improves the long-term risk of PCOS, like insulin resistance, cardiovascular disease, hyperandrogenism, and menstrual cyclicity. So the main line of treatment is lifestyle modification. This is the first line, in addition to oral contraceptive pills, metformin, anti-androgen. Now, my question here, could liraglutide be useful in girls with polycystic ovary? Who says yes? Yes, why not? Because they are obese. Recent research published in 2020 showed the GLP-1 agonist improves obesity, androgen excess, and reproductive function. And here you can see in this research, it improved the bleeding, testosterone, ovarian volume, but it is not yet approved formally in those girls. And here you can see it improves the androgen index. And finally, we need to redirect the arrow, because prevention and early treatment of obesity is crucial. My final point is obesity and type 2 are preventable. Remember that food is the most abused and anxiety drug. When we are happy, we eat. When we are sad, we eat. When we need to do anything, we eat. And exercise is the most underutilized antidepressant. Please leave your drug in the chemist pot if you can cure your patient with food. This is what Hippocrates said. And let your food be your medicine, and your medicine will be your food. Obesity is a chronic disease. It affects the aspect of people's life from health to relationship. And finally, remember, childhood and adolescent obesity is a growing global problem. Arab children are among the heaviest in the world. The prevalence of type 2 diabetes is much higher in adolescent. Inflammation is the root. The horizon of anti-obesity medication, including liraglutide in adolescent, is expanding. And remember, obesity is only the tip of the iceberg. Don't forget to dig for other features to fight this wave. And my final slide, again, بعد كل اللي قلته, let me ask you again, which is stronger? وانتوا شايفين الشوكولات كيك الحلوة دي. Which is stronger, the food or our will?
Food.
برضو? Thank you very much.
والله يا دكتورة احنا